Aber Sie sehen die Teilnehmeranzahl eher auch nebenbei, oder?
Genau, genau. Okay, so Takeo, we have now 5 minutes and we have 4 participants. As I can see, there's Walid, who knows the lecture.
Okay.
There's Imad Ullah from the WFNS group, Lucas Lima from South America, who is one of our participants on the committee. And there's your Dr. Nakada. What do you think? Shall we do it for only 4 people as well? What is a suggestion?
Okay.
5. Let's get together. 5? Who can? Okay, I don't know him. Well, anyway, then I think we should do. If we don't do it, then it will never take off. Yeah. So maybe in a couple of minutes we have more participants.
Yes.
So
with the past time. So let's start.
I think Dr. jetzt hin, oder wie?
Ich teile die Bühne genauso.
Okay, dann mich groß aus dem Schirm, bitte.
Ich glaube, Sie sind es nur die eine. Das ein Bild jetzt eventuell.
Ja, ich sehe groß.
Da sollte um den ich sage, Sie sehen einen orangen Rahmen, aber das sollte eigentlich groß sein.
Na, ich sehe jetzt gar nichts, aber the first WFNS webinar of the NeuroEndoscopy committee. We plan to do this as an educational webinar series where we really want to more anterior, we go 6 centimeters anterior to the coronal suture, and same laterality, pineal cyst, even more anterior. If we want to remove a colloid cyst, we not only go anterior but also lateral, because we want to dive in just over the head of the caudate to reach the head, the the roof of the third ventricle where the cyst is emerging from. And if we do a septostomy, we usually come from very lateral to have a good perpendicular approach to the septum to do that. So that's the standard that we learn, and we know that it works in most cases. Here are some pictures that we know from the book of Henry Schroeder together with the Stolz company, how to use endoscope for third ventriculostomy. Here you see from the same book, the septum pellucidum fenestration, as I showed you, as I told you, just 6 centimeters lateral to the midline for perpendicular approach to the septum, and colloid cyst, very anterior approach and lateral to see the roof of the third ventricle. So, but still the complication rate is far from zero. Yeah, if you look at this meta-analysis of about 3,000 third ventriculostomies from the Spiroskouros group in 2013, then you see there are complications, and the complications, are far from zero and may even involve 2.2%. And why is that? It's major because of bleeding, because of basilar rupture, severe hemorrhage that is in fact from poor technique or, of course, anatomical variations. Let me show you some of my own experiences. Honestly, I was not one of those three, but that's the experience that I had in my vision during assisting surgeons. So this is a recent one. So this guy is advancing the endoscope with free hand, and he said he has done it forever. It's very easy to reach the ventricle, and honestly, the is quite big in this 17-year-old kid. And this is an uncut video, and if you don't find the ventricle, you have destruction in the, in fact, basal ganglia, because if a bit closer and if the image becomes less blurred, then you see this is stratum that we encounter here. So here, that's stratum. Yeah, so we are somewhere in the here. If we look a bit further, we do a second attempt. The guy thinks he can still do it. Second attempt. Now you see the destruction of the endoscope. It's about 6 millimeter endoscope. It's like a bullet, and you see, lots of destruction. Yeah, so still doesn't find the ventricle. Let's go further. He has now punctured Cushing needle the ventricle successfully, and for the third time he's looking for that Cushing needle, and you see it's on the left. Here it is. So he was too lateral, and you see this is not a small foramen of Monroe. This is not a small third ventricle. So still he has two, let's say, attempts advancing the endoscope, creating a lot of damage in this boy's brain. I think this is totally unnecessary. And here's another one. It's only a picture, not a movie. If you position the entry point too far anterior, that's what you get. You get a contusion of the fornix, because then you have to leverage to tilt your endoscope anterior, and that means that you will put some power on the fornix, which of course damages it here. And here's a third one that I like, because again it's from very experienced neuroendoscopists, and the endoscope was kind of blurred. Obviously the optics was not ideal. Yeah, and they said they have done the perfect target point. But what you can see already here is the infundibular recess. So it seems that the perforation point is far lateral to the midline. Yeah. So imagine what happens now. So the assistant is blowing up the Goto balloon. Yeah. And of course, you can imagine that below this, you may find some posterior communicating artery, and exactly what happened. So he avulsed the PCOM completely out of the P1, P2 junction, and this patient died about 3 hours later after angiography. So I think this is not necessary, these complications. And if we use navigation, and most of us do have navigation somewhere around, if we use navigation, we can probably avoid these devastating complications. And we published in 2004 surgery this paper, how we you can very easily best make neuronavigation suitable for your surgical ostomy. So let me talk to you a bit about this study that we did at the time. So because we had some complications in my hospital, we did a retrospective analysis. How was it really done? How was the ETV performed? And it was performed with manual planning without navigation guidance. So we had 59 cases of those. So look how what we compared. So we compared a manual plan. Yeah, we compared a fixed burr hole, like I showed you before, 2.5 centimeters or 3 centimeters lateral to the midline at the coronal suture. And we did a navigation plan in all 59 cases. Here's the manual plan at that time. What we did, we used films and we measured with a ruler, we measured the optimal position of the burr hole. And then we went to the patient on the OR table, put the ruler there and marked the optimal entry point. Okay? So that was what was really done. We had a burr hole in the CT scans of these patients. So we could compare entry and target point position. And then here is the second method, the fixed burr hole. Yeah. And then here is the navigation plan. And I would like to show you what recipe, what plan we made to do this perfectly. It's a bit like a biopsy. So you set a target point just posterior to the dorsum cellae, anterior to the basilar artery, as you can see here. Then you define an entry point in the center of the foramen of Monro, like with a biopsy. And then you elongate this to the surface of the skin. And then on your 3D model, you can reset the optimal entry point disposition. Of course, you need some maybe refit afterwards because you don't want to cross the cingulator sulcus and you don't want to cross any sulcus here or artery. This is in fact the perfect trajectory to your surgical ostomy. Then we tested the position of the entry point and the distance of the trajectory to the foramen of Monro, like to here, to the fornix, to the thalamus, and in the third ventricle to the thalamus and the hypothalamus. Here you see the results. And this was quite striking. The blue, you see on the left side, you see the manual plan burr, yeah? And they were mostly at or anterior to the coronal suture. In red, you see the standard burr hole, 3 centimeters lateral to the midline at the coronal suture. And on the right side, you saw our navigation plan. And interestingly, this navigation plan is very different from what these people had done in the 59 cases in reality. So it was at or even below. So here are the results. You see, the manual plan that was, the manual plan that was really performed was about 7 millimeters anterior to the coronal suture. Of course, the fixed burr hole was at the coronal suture. The navigated one was a bit behind the coronal suture. And if you look at the trajectory, how often did it displace the fornix? We can see that our manual plan displays the fornix in 50%. So in 50%, you probably had the contusion of the fornix. And in 10% of the thalamus, hypothalamus. The fixed burr hole would have been much better. Only in 25% of patients, you would have displaced the fornix. But the navigated trajectory is much better. It never takes. And only in one case, it touched the hypothalamus and thalamus. So this was very striking. And we thought we have to use this way of planning surgical ostomy. And so then we designed a navigation protocol, and we designed the navigation protocol first with optic tracking. So this is a standard endoscope. You can mount this universal instrument adapter, I think, on every endoscope worldwide. We use this because we had it. We also thought, well, you can even use electromagnetic tracking if you have it. You can use both, yeah, but of course, electromagnetic, and I will show this to you, has some advantages because it has a pointer. It sells this stylet that you can actually fiddle through the channel of your endoscope and then track the tip of your endoscope. So here is what you saw before. That's the endoscope emitter, and that's the patient reference tracker, and initially we place the patient in the head clamp, which we don't do now, and we place the stylet inside the working channel, and then you can move. What we do now is very different. We use what is called a flat bed emitter. So this emitter is where the patient's head is lying on. We don't pinning anymore, no for ventriculostomies. Yeah. Then the flatbed emitter creates this magnetic field around the head. We don't use either the skin adhesive or the bone anchored patient reference trackers because we think this is too invasive and this is not high accuracy because we don't want to train. So we use the inside of this tracker. We just pull it out and put it in a nasal tamponade, and then using a speculum, we put it in the patient's nose. And as endoscopic skull-based surgeon, like my colleague and friend Takeo Goto is, he knows very well how to place this in the nose because we do it at some end of pituitary procedures. And here you can see on the right side the results. You see the green one, the green curve is the skin adhesive tracker, how it becomes less accurate throughout the procedure. So when you drape, you kind of move the tracker. So it's very inaccurate. Whereas the nasal tracker stays very accurate throughout the procedure because, of course, it cannot move inside the nose. So this is what we use. You see here the nasal tracker, and that's our setup. In fact, every ventricular endoscopy registration, as you can see here, I have a CT scan made so that we come below 1 millimeter accuracy. I think that's important because sometimes the structures in the prepontine system are very narrow. And then we use our stylet inside the endoscope and it's to the third ventricular floor. And we even use the stylet to puncture that hole because the stylet tip here is very blunt. And it's very useful to create around 1 millimeter hole, 1.2 millimeter hole. And you can use it then for the Fogarty balloon to enlarge it. So here is just an example. Yeah, you see the endoscope always shows up in the middle of the foramen of Monro. That's not a very big, but it's big foramen, sufficiently big foramen. So it always shows up in the middle of your foramen of Monro. Yeah, so it's very easy to advance the endoscope further. And you see on the left side, the concurrent navigation, we're advancing exactly along our trajectory. And we're advancing now to the target point, which is, of course, here. Yeah, and you see how accurate this is. And then we can use our stylet. We advance here our stylet. We usually touch here the clivus, or the dorsum cellae, and then we create a hole right behind it, which is very easy because you just do a blunt puncture. You see? That's super, yeah? And you can use it, of course, for every puncture inside the ventricle. And once you have this, yeah, you use your Fogarty balloon. You can do more than one, of course, and then you use your Fogarty balloon to enlarge this, yeah? Because you can use the same hole and just enter with that balloon and enlarge it. So I think this is very simple and straightforward. And then at that time, we applied this recipe, this technique in 16 cases, yeah, like as a prospective trial. Here's one of the cases I remember, the Lermite-Duclos disease of the cerebellum. And this patient had very thick mantle, and you see how long it takes to get vision. And only suddenly you find vision. So it's very easy here to miss the ventricle. Yeah. So I think it's very important to use navigation while we pass through the cerebral mantle. Here's another example at that time, how we advancing the here, see, we're advancing the endoscope and we're perforating the premommillary membrane. I think very straightforward and simple. And once we have made our perforation, we use the ideal Fogarty balloon, as you can see here. Yeah, we pass it through very easy. Or we can use the double balloon. But let me advance to the end. So we have, at every end, we assess the fornix loop. And you see here, we have not touched the fornix loop at all. Yeah. So there's no contusion whatsoever. So I think this is really how we should do a perfect third ventriculostomy. Like this one, that's a 32-year-old male with a pineal and suprasellar tumor with hydrocephalus. So I remember, of course, with acute hydrocephalus, so we needed to do something. So there was no chance of acute irradiation or chemotherapy because, of course, we think, well, we know this is a germinoma from the double pathology. Normal, we would not do a biopsy, but we did some CSF diversion. So we could do an external drainage or we could do a third ventriculostomy. So we opted for a third ventriculostomy here. Ventriculostomy is covered by tumor. So we knew we need to remove some tumor to get to the floor and do a biopsy at the same time. So along our pre-planned trajectory through the foramen of Monro. Here you see the tumor. Yeah. Here you see the mammillary bodies. Yeah. So this is not the place to do your third ventriculostomy. It's behind the basilar. Super dangerous. In fact, you never do it. And so we needed to remove some of that tumor, which was very easy because it was very avascular. Yeah. And free our area for colostomy. So we did that. And let me advance a bit and did some coagulation. Yeah. And you see here is our membrane coming into vision. Yeah, so here's the basilar now. We know that we can see it here on the left side on our navigation system, and we create a hole and do our Fogarty balloon enlargement just anterior to the basilar artery. Yeah, and this was sufficient enough to keep this patient pressure free until he received his therapies. Yeah, and you see just here a slight touch of the fornix, but otherwise very, very, I think, successful. Yeah. So I think for the sake of time, I will continue here. So remember, we did 16 cases and tested this procedure out, and in all of them, we had no second pass, we had no hemorrhage, yeah, and we also never touched the fornix and never touched thalamus or hypothalamus. So we thought that this is very, very useful for also other pathologies. Yeah. And here I show you some other indications. Of course, you can reach every place of the third ventricle in this method. Like, for example, here, pineal region tumor. If you want to do a biopsy, you place your target area here. You place your entry area in the foramen of Monro, and then you elongate it, and you see that you're quite close to the head. Frontal area. Here you have your ideal burr hole, and that works well. Yeah, you see it here, same posterior for supplying. That's how you do it. Out is very similar to what we learn. It's specific, yeah, and patient specific means you will not harm the anatomy. And also with our friend from Brazil, we did another technique how to reach larger areas of the third ventricle by opening the choroidal fissure. Yeah, and you see here, if we want to reach tumors of the third ventricle posterior to the foramen of Monro, in many cases you need first a third ventriculostomy, and you need to reach the area behind to remove the tumor. So you have a second trajectory, and this one in between is the area that you have to open or push your choroidal attack. Yeah. So the best thing is here to minimize damage, to get this angle, yeah, and approach with your endoscope through the middle, yeah, and then you can shift a bit anterior and shift a bit posterior. So you have the least damage to the brain, and this is quite very helpful in many cases, like in this one. Let me show you this recent case, a 39-year-old with a cranial cyst. So it's a huge of the posterior fossa reaching to the cranial cistern. Yeah, Here you see it's pre-op imaging. He developed the hydrocephalus because of the outflow obstruction in the aqueduct. Yeah. So of course the idea was what to do. Well, of course you could try to perforate this cyst somewhere in the choroidal system, but that's usually not the way it works. Yeah, because it's dangerous. There's no area in front of the membrane, so you will directly puncture the plate. And on the other hand, you can of course fenestrate to the lateral ventricles. You can do that from below, but of course again much more difficult than to come from above, and because from above you can see the fornix, and you don't want to harm the hippocampal commissure of the fornix. So we did our plan here. So that's actually the puncture site that we wanted to use. You see that here. That's the old shunt this guy had. Yeah, that's the internal veins, which we don't want to harm. So that's our target area. And then, of course, you want to do third ventriculostomy because very obviously his shunt didn't work. And I think it's a very good indication for third ventriculostomy. But we did want only to use one burr hole. So we used our recipe from here again and divided this angle, as you can see here, a bit more posterior because I thought this was more important than the third ventriculostomy. And so to reduce the damage to the brain. That's again our setup. That's again our registration. I showed you this. So we introduced our, you see here, guidance tube, and then finally the endoscope with the in the working channel. And you see we are now moving along the middle trajectory, yeah, and looking to posterior. Here we see now the shunt, yeah. That's the plexus, of course. And then we inspect the target area. Look, we are now along our pre-planned trajectory, and you see here's the fornix. Here's the fornix loop, and here's a very translucent area that we can use just behind the hippocampal commissure. And we use again our stylet to puncture this area, yeah, and our Fokker balloon to enlarge it, yeah. That was a bit tricky because it was very stiff ventricles, yeah, but we finally succeeded, yeah, and enlarged this slit, and suddenly the part fell a bit lower. We're now perforating the arachnoid cyst membrane, but because we always know where we are. And then finally, we check with our endoscope through this generated hole to the cyst. So here you see posterior cerebral artery. Yeah, on the other side was the internal cerebral artery. And here you see this large cyst cavity. So just between the vein, we enlarge this. And you see at the step, now this hole is much bigger because there's a step created. And now finally we advance our endoscope anterior again. Yeah. And don't forget, it looks very far, that the tilting, but it's only half. It's only halfway because we have divided our angle. Now here's our for, and of course we will do now the third ventriculostomy just in the way that I showed you before. I don't have to show you this again. So this was did very well. Now, just a short comment. I think I have a couple of minutes on the project. Well, we developed the small autoguide robot for biopsies and SEEG placements actually in the last years. Here's a kind of history how we did that. And our endoscope with bare hands, right? Has to show that how steady he can hold the endoscope. Why not use a real device like a robot, where you can use a remote control to move the endoscope? Like in this case, yeah, this is only a mock-up, not a real surgery. So the idea how to move the endoscope with the joystick. So this is where we are now. We have now received FDA clearance for this setup. So that's the autoguide robot in a modified version. The modified version is actually able around the target area. So I think this is very, very important. Yeah. So I try to show you that if you use navigation scope to the third ventricle, yeah, may reduce mobility in the future a lot. Yeah, you may not only save the fornix, but you also may save basal ganglia. You may prevent add to the safety of the have to